Right, good morning, and welcome to Methodist DeBakey Heart and Vascular Center Grand Rounds. Today is Vascular morning, and I'm delighted to be able to introduce one of the real experts in aortic disease, particularly in endovascular approaches to the aorta, but also with huge experience in open repair, and that is Dr. Adam Beck. Dr. Beck is a Holt McDowell Endowed Chair of Vascular Surgery, and he's the Division Chief in Vascular Surgery up at University of Alabama, Birmingham. And he also has a significant role as the Director of Quality and Associate Chief Medical Quality Officer in the Cardiovascular Institute at UAB. As I said, he's internationally known for his expertise basically around aortic work, and has really been one of the pioneers in developing branched approaches to almost every different component of the aorta. He spoke last night really about total endovascular approaches for the entire aorta, but today he's going to focus really on one of the feared complications, and that is spinal cord ischemia. It's one of those things that you pause when you're talking to the patient. You can do a perfectly straightforward operation, the patient wakens up paraplegic, and it's a life-altering complication frequently associated with mortality. And so it's one of the things that's really limited thoracic aortic surgery. And so we're really interested to hear some of the work that's being done about how do we mitigate and reduce the incidence of spinal cord ischemia. So Adam, I know you've been in Houston 3 times in the past month, so thank you again for coming back down and educating us. Appreciate it.
Thanks, Alan. Thank you to everyone for having me. As I said last night, it's a little bit daunting to come to the mecca of aortic surgery and talk about aortic surgery, but it's really nice to be here again. This is my 3rd time in Houston in a month, as you said, and it's always nice to visit. I lost my voice during the weekend, and it's just coming back, so I apologize for that, and hopefully everybody can hear me okay. So I am, as Alan said, I'm going to talk about spinal cord ischemia. It's something I've kind of focused on for much of my career, and going to kind of work through a little bit of the history of it, and then talk about some of the ongoing work that we're doing in that area. These are my disclosures. All of my consulting work, the remuneration for my consulting work goes to UAB and not to me personally. So I've been talking about spinal cord ischemia and aortic repair and the implications of spinal cord ischemia, so what happens afterwards, some of the mechanisms of injury, and then really focus on endothoracoabdominal repair and show you some of the work that I've done at the University of Florida and UAB, and then some of the work we've done in the group, the US Aortic Research Consortium, and what we've learned from that large experience of patients. So why focus on a complication? All the surgeons in the room probably know this quote from René Lariche, that every surgeon carries within himself a small cemetery where from time to time he goes to pray. And I used to have one of my mentors at Dartmouth used to talk about his, quote, messed up pile. So he had the patients that he had not only had die, unfortunately, but the patients that had severe complications that carried through the remainder of their life, which often is short after a severe complication like spinal cord ischemia, unfortunately. The implications of this complication with open repair, if you have spinal cord ischemia, your mortality is 45%, the perioperative mortality. Without spinal cord ischemia, it's 4.5%. So you can see it's a 10-fold increase in the risk of mortality around the operation. With thoracic endovascular aortic repair, the 12-month survival of patients that have spinal cord ischemia that's irreversible is 25%. And those without spinal cord ischemia is also soberingly low at 85%. So these patients are sick patients who often have other medical comorbidities, so they're not dying from their aneurysms, they're dying from other things. So as I said, why do I focus on a complication? Jim Seeger, may he rest in peace, was my first boss at the University of Florida, and he used to say all the time, write about what you do. So for the young folks in the room, a lot of times you worry when you're coming out, if you're going into academics, am I going to have any good ideas about what research to do? And all of my ideas have always been somebody else's ideas. Well, that's generally true when you're finishing your training, but every day you will have clinical questions that hit you with the patients that you see, and if you write about those things, you'll really build a passion in it. I participated in a symposium at the Society for University Surgeons. It was about sort of finding your passion in your career, and one of the speakers that was adjacent to me was Gretchen Schwarzy, who's a vascular surgeon at the University of Wisconsin, and she always says, study something you hate, and I hate this complication with a passion. As Dr. Lumsden said, you can have a perfect repair. You can do everything right, you feel like, with your repair, and the patient can wake up not moving their legs and be paralyzed, which is a really demoralizing thing as a surgeon. Thoracoabdominal aneurysm repair historically, as you all know, has been an open surgery. This is a picture I showed last night too. It's an extent 2 thoraco. We basically open the patients up like a biscuit can, and this is essentially the largest operation that you can have as a human being and survive it as an extent 2 thoraco. And the complications of this are vast. These patients with an open extent 2, essentially 100% of patients are going to have at least one major complication after that surgery. And of course, there's major complications and there's major complications. You can die, or you can have a minor MI, or you can have spinal cord ischemia, and that spinal cord ischemia can be anything from my leg is mildly weak and it comes right back to I'm profoundly paralyzed and will never walk again. Historically, the paralysis and paraplegia rate for an extent 2 thoraco back in the days when they first started doing these was upwards of 40% when they were clamping and sewing aorta. So it was a pretty daunting operation for patients. So why does that happen? There are fairly obvious mechanisms of injury: the aortic cross clamp and decreased perfusion to the spinal cord, hemodynamics, so if the patient becomes hypotensive during the operation, and then ligation of important peripheral feeding vessels to the spinal cord from the intercostals or lumbars, the subclavian and hypogastric arteries. This is a seminal paper on the topic that Dr. Wynn and Aker wrote from the University of Wisconsin, and his wife, Mimi, was his cardiovascular anesthesiologist throughout his entire career, so she did all of his cases with him. CW was really interested in spinal cord ischemia, and I kind of met him around this complication. When I was very young in my career, he came up to me after I gave some talk at some meeting, and we talked for a couple hours about spinal cord ischemia. It kind of helped build my passion in this area. But this paper is really a phenomenal paper if you have any interest in this topic, where he and his wife basically go through all of the mechanisms of injury and then what they were doing to prevent that injury. Decreased blood flow, decreased oxygen delivery to the spinal cord, cell injury, and reperfusion injury to the spinal cord sort of sums it up. They have a whole protocol that they had developed around prevention of spinal cord ischemia at the University of Wisconsin, and I actually went up and visited them to see this because, and I'll show you some of my data from the University of Florida when I was early in my career and was having some spinal cord ischemia events, as I said, were quite demoralizing to me. So I went up there to see what they were doing, and I essentially took their protocol and applied everything I could to an endovascular repair in my protocol. Some of the things we can't do anything about, for example, for covering intercostal arteries, if they come off of aneurysmal aorta, you have to get seal and fixation above and below that aneurysm, and you're going to cover those vessels. Before I get into that, the open repair has a number of adjuncts that we use to decrease the risk of spinal cord ischemia, as listed here. CSF drains, distal aortic perfusion, intercostal reimplantation, expeditious surgery, my favorite one, operate fast, hypothermia, spinal cooling, and neuroprotective drugs like barbiturates or propofol is what I use for burst suppression. This is to decrease the metabolism in the spinal cord and its oxygen demand. With these, depending on the extent of disease and the experience of the center, the spinal cord ischemia rate can be in the 2 to 20% range, with, of course, the patients with more extensive repair having a higher risk of spinal cord ischemia. So what about endovascular repair? This has been around for quite some time now. The first successful TVAR was reported in 1994. The first device that was available in the U.S. commercially approved was the Gore tag device in 2005 was when it was approved. As I said, very simply, you have to get seal and fixation above the aneurysm in order to get a successful repair. And back to this paper from Wynn and Aker, like I said, we tried to apply these principles to endovascular repair. The TVAR coverage, because of the coverage of the intercostal vessels, if you do an EVAR in the infrarenal aorta, you decrease flow to the lumbar vessels. When you have sheaths in, for a long time, you decrease flow to the internal iliacs and to the profundifemoris arteries on both sides, especially if the vessels are smaller, and so that causes an ischemic injury. And when you remove the sheath, you can actually get a reperfusion injury to the spinal cord. And all of this is really aortic coverage. It's all related to aortic coverage. This is a really nice paper on this subject that they wrote at University of Florida, and this was before I arrived there in 2009. This was in 2008, and at the time they had, I think this was 600 T-bars at the time, and what they found was in univariate analysis, they found a number of risk factors for spinal cord ischemia, but in multivariate analysis, you can see here the age, male, gender, higher ASA class, a longer operation, which probably was just a surrogate for complexity, all were related to spinal cord ischemia. But what were the strongest predictors were aortic coverage length, and then if you measured from above the celiac artery, the more you covered above the celiac artery, which is a watershed area for the spinal cord perfusion, and the location of the artery of Adamkiewicz, you increase your risk of spinal cord ischemia. And this graph is actually my favorite thing from this paper, and it'll take you a second to kind of take it in. But what this is it's essentially mapping the amount of aortic coverage that each of these patients had. So on the top of the graph is the patients who had spinal cord ischemia. On the bottom are those that did not have spinal cord ischemia. The white is the uncovered portion of the proximal aorta from the left carotid artery down to the covered. Blue is covered aorta, and orange is above the celiac artery that was uncovered. So essentially what it's showing you is that all the patients that had spinal cord ischemia had more aortic coverage in their chest. There were some patients on the bottom that, of course, had the similar coverage and did not have spinal cord ischemia, but the ones that did have spinal cord ischemia had more aortic coverage. This is a later paper that we wrote that was 741 patients, and we were trying to look at preoperative predictors of spinal cord ischemia so that we could try to have some data to discuss this with the patients in the clinic. And that will not advance. There it goes. When we looked at this 741 patients, 9% had any level of spinal cord ischemia, and 5% had some permanent deficit. Now, these weren't necessarily paralyzed patients and couldn't walk. They could just have a minor deficit, and some couldn't walk. But the interesting thing is if we looked at the first 100 patients in that series, they had 9% spinal cord ischemia. We looked at the last 100 patients, 9% had spinal cord ischemia. So we hadn't really moved the needle very much at that point in reducing the risk of spinal cord ischemia. We took all of those patients and looked at the length of coverage. So we did this a little differently than the previous paper. We actually looked at from the sinotubular junction to the bifurcation as the total length of aorta, and we calculated the length of coverage and the percentage of coverage. So the interesting thing, I have this picture on the right there, is that not everybody's aorta is the same length, right? So a really tall person has a much longer aorta than a very short person, and also you'll often see, especially little old ladies who've got these big thoracoabdominal aneurysms in their chest. The aneurysms don't just grow in diameter, they grow in length, and so the aorta grows in length as you get older, just naturally, and so it has to go somewhere. So you get this big tortuous aorta, and so you can have a little short lady who's got a very long aorta as a crow flies through the center line of their aorta. So the probability of spinal cord ischemia increases with age, as I mentioned, but then aortic coverage length in this paper, again, was the biggest risk factor for spinal cord ischemia. This is, we also looked at indication for the treatment, and what is on the y-axis here is the number of repairs done for that indication. On the bottom is the indication. Far left is thoracic aneurysm, which was the most common indication. Chronic type B aortic dissection, acute dissection, penetrating aortic ulcer, and so forth. And you can see the thoracoabdominal patients at the time, 15% of them had spinal cord ischemia of any degree, and thoracic aneurysm, again, 9%. So that was always the number, was 9%. Now I want you to keep these numbers in your head because I'm going to show you some data that we were able to obtain after we developed a protocol, which I was shocked by after we did it, and it actually has persisted up until now. So we've decreased this rate substantially. So in this paper, we took these risk factors for spinal cord ischemia. This is just essentially a predictive model that shows if your age was 80 or greater and you had 300 millimeters of aortic coverage, and you had a history of hypertension, you had upwards of a 20% chance of having some level of spinal cord ischemia with your repair. So the question is this really the Achilles heel of endovascular aortic repair? And what happens after this, after you have spinal cord ischemia? This was another paper that we did at UF, and we specifically looked at the patients who had spinal cord ischemia, and we reached out to all of the family members and the living patients and had a questionnaire for them. And at the time, there were 609 TVARs. So these were, for the most part, were isolated to the chest. We had 57%, again, 9% of the patients had spinal cord ischemia. The in-hospital mortality of those patients with spinal cord ischemia was 7%. So the implication of that in-hospital mortality number is a good bit different than it is with open thoraco repair. Remember that 45% number that I gave you before. And the issue is that, especially with open repair, spinal cord ischemia doesn't usually happen in isolation. So these patients will often have an MI, sepsis, pneumonia. They get some other complication that often leads to hypotension, and then they get spinal cord ischemia. With endovascular repair, that's not always true, but it is sometimes true. Of the patients we were able to contact, 76% of them said that they had at least some subjective functional improvement, and 35% of these patients said that they returned to their baseline. If we looked at all of the patients and just followed their Kaplan-Meier curves, you could see there was a pretty profound effect of having spinal cord ischemia. So no spinal cord ischemia, Kaplan-Meier curve on the top, any level on the bottom. So there was a big difference in the mortality over time. And the median survival of the patients who had spinal cord ischemia was 37 months versus 72 months for those that did not. But if you broke it down further and looked at the patients who returned to baseline or not, you had a really profound difference in how these patients do over time. So if the patients didn't return to baseline, you can see that their mortality is very high out to a year or 2 years. And then if we look at the any functional improvement, if the patients say, I did not improve at all, their mortality or their mean survival was 3 months. And so those patients die. They don't die from the spinal cord ischemia. They die because of pneumonias and decubitus ulcers and sepsis and UTIs and the things that people that have spinal cord injury get. So it's not just important to prevent spinal cord ischemia, it's also important to mitigate the severity of spinal cord ischemia. And so we want to do all the things that we can do to prevent it, of course, but we also want to decrease the severity of it when it occurs. So those were all thoracic endovascular repair, mostly isolated to the chest. Some were thoracoabdominal repairs, but most of those papers I just showed you were written very early in our experience with branch and fenestrated repair. This is Tim Tudor and Roy Greenberg. They were the fathers of endovascular thoracoabdominal repair, had some different philosophies about how to treat it, but the bottom line is they were sealing above and below the aneurysm with these repairs. And when Dr. Greenberg he has since passed away, as all of you know, but he was at the Cleveland Clinic. He had an enormous experience with endovascular thoracoabdominal repair before many of us were even doing these at all. And what they did in this paper was looked at open surgery patients at Cleveland Clinic versus the patients that had endovascular repair. And this is freedom from spinal cord ischemia, and the dark line, if you can't see it in the back, is the patients that had open surgery, and and those on the dotted line are endovascular repair. So you can see that the rate of spinal cord ischemia was lower for those that had an endovascular repair, but when you break it down by extent, you see some important data, and this is a very busy slide, but I'm going to kind of break it down for you. So on the left here is the extent of coverage. So extent 1, 2, 3, thoraco, ER is endovascular repair, SR is surgical repair. What I've highlighted in the box on the right is the mortality at 30 days. So for extent 1, thoraco, endo versus open, it was actually higher in the endo repair patients, but for extent 2s and 3s, the mortality was less than a half, almost a third for the extent 2s, and 9% versus 12% for the extent 3 patients. So mortality, if you added all of these up, was better for the endovascular repair. And when you look at spinal cord ischemia on the right there again, endo on the top, surgical on the bottom, 10 versus 14%, 19 versus 22%, and 5 versus 10%. So if we look at the patients who had the longest length of aortic coverage, the extent 2 thoracoabdominal aneurysms, the spinal cord ischemia rate was actually very similar between endo and open repair. And when, this is a subsequent paper by Tara Mastracci and Matt Eagleton when they were still at the Cleveland Clinic, and they really focused in this paper on the patients with the most extensive coverage. And if you look at the extent 1s and 2s, they had a 10 and 19% risk of spinal cord ischemia, respectively. That paper gave me comfort at the time because I was that was written a little bit before my experience, but I was getting maximally frustrated with this complication in the kind of 2012, 2013 range, and I was putting together my investigational device exemption study and I was doing a lot of physician modified grafts at the time. Got my IDE in 2014, and at that point, not only did I have to suffer with the thought of the patient having spinal cord ischemia, I also had to report it to the FDA. And so I had to write up these reams of paperwork to tell the FDA and the IRB about the rate of spinal cord ischemia and what I was doing to prevent it. And so for better or for worse, that made me obviously focus on this even more. So these were what I had in around 2012 or so, and I had 243 patients that I'd done fenestrated repairs, branched or fenestrated repairs on. And what this says, if you look at the x-axis, is juxtarenal, suprarenal, and increasing length of coverage, extent 4, 3, 2, 1. And the risk of any spinal cord ischemia in the extent 3s and 2s was 32% or 18%. These are astronomically high numbers. Now, any deficit we were calling spinal cord ischemia unless we could prove it was something else. So we were pretty liberal with what we were calling this. And then if we looked at the recovery afterwards, the juxtarenal suprarenal did not have spinal cord ischemia. The extent 3, 2, 1, there were 5% that had a permanent deficit, 11% that had a permanent deficit in the extent 2 patients, and all of the extent 1 patients recovered. And I'm going to talk to you about a protocol that we developed that were based on these data and my visit to the University of Wisconsin at the time. But so we were wondering, well, what can we do? I think, we know that prevention is key. We want to rapidly detect this. I did some work with one of the neuroscientists at UF, and we took some of the CSF and looked for some biomarkers that he had determined were associated with outcomes after intracranial aneurysm rupture. And so we looked at those same CSF biomarkers in patients with spinal cord ischemia. One was a axonal marker and one was a pericardial marker. And what we found was they were high, but the timeline to seeing those took longer than what your physical exam would show you. And so the most important thing is that you have to get a good physical exam on these patients, and you cannot ask them, for the junior trainees in the room, you cannot ask the patient to wiggle their toes. You don't want them to just wiggle their toes. You want them to lift their legs off the bed. That's what you want to see, lift them off the bed. Because most patients can still wiggle their toes early in the course, and the loss of sensation is a very late event in spinal cord ischemia. So if they've lost their sensation long before that, because this is usually an anterior spinal cord infarct, they're going to have a motor deficit before you see that. So anyway, the upshot of all that is the biomarkers were not, they're interesting, but they were not that informative as far as detecting this. And then some people are using sensory and motor evoked potentials intraoperatively. I did this for a while, and I didn't really find it to be that useful. Everybody's motor evoked potentials will drop when you put your sheaths in. And so you can tell that they get some pelvic malperfusion from that. But I never really was using this as a way to monitor the patient. And if the patient's awake in the ICU, you can't really do these things. What we did determine was, and after I visited Dr. Aker, I realized that this really needed to be protocol guided, and everybody needed to be educated about how we're going to prevent it and how we're going to determine when the patients have this complication. This paper from Dr. Greep, who he really has written many of the seminal articles on this topic from his group, and he has recently passed away, but this was written in 2012, and this was about the anatomy of spinal cord circulation, but there's also some interesting data in here that they found when they looked at ligation of the segmental arteries in juvenile pigs. And so what you're looking at on that image, if you can see my my pointer up there. So what they did was they ligated different parts of the collateral flow to the spinal cord. On the far left, they just kept ligating the segmental arteries until they got to a number where they lost function in the legs. And so with just ligating those vessels, you had to ligate all of the thoracic segmental vessels and some of the lumbar. But if you ligated the subclavian arteries, so that perfuses the vertebral arteries, which have a direct collateral flow to the spinal cord, and also the shoulder collaterals, that led to spinal cord ischemia with less segmental ligation here. So this tells you that things like a carotid subclavian bypass or covering the subclavian artery is you don't want to cover the subclavian artery in an elective patient if you can avoid it, because there are some very important collaterals to the spinal cord, particularly off of the vertebral artery. But interestingly, on the right side here, if you ligate the median sacral artery on these pigs, this is a very important collateral blood flow to the spinal cord, because you only had to ligate 4 segmental vessels for those pigs to lose their lower extremity function. And this was interesting, because right around this time I was having a debate with the neurosurgeons at UF about whether hypogastric arteries had any importance in spinal cord blood flow, which to me was sort of a no-duh kind of thing, but they were absolutely refused to believe this, and I had to go and give them grand rounds, and we put all these things together to show them that they absolutely does. And if you spend enough time in vascular surgery, and I'm sure that some of the older vascular surgeons in the room can tell you that very occasionally you'll get patients with an acute aortic occlusion or acute hypogastric artery occlusion who'll come in paralyzed. And so there's no question that flow is important for spinal cord perfusion. This is another paper from Dr. Greep's group, and this is 2 years prior to that. And what they were looking at was the patients that had similar lengths of aortic repair, but either at one stage, so these would be an extent 2 or an extent 3 thoraco fixed all at once, versus patients who had a previous infrarenal or extent 4 repair who then had to come back and get a thoracic aortic repair, or the converse. And what they found was that the patients that had a single one-stage repair, had 8 of the 55 patients had spinal cord ischemia. And what you're looking at here is the number of segmental arteries that were sacrificed. Over here on the right side, the yellow are the patients that had, or the previous repair, and black was the repair at the time of the index operation. And 35 of these patients, out of 35, they had no paraplegia. So these were long-staged operations, though, and they weren't intentionally staged. So they didn't say, well, I'm going to do this part today and do this part in 3 months. These are patients that had part of their aorta replaced in 2002 and then had the other part replaced in 2007. And so, but those patients had a very low risk of having spinal cord ischemia nonetheless. So back to this again, like I said, we were working on a protocol at UF to try to decrease the risk of this. And this I don't expect you to be able to read this. I just want to point out that we had elements of the protocol that we use in the preoperative phase. This is things like holding blood pressure medications and allowing the patients to be permissively hypertensive. Intraoperatively, we pushed their blood pressure up. We had a mean arterial pressure goal of 90. We optimized their hemoglobin levels. So we wanted a hematocrit of 30 or hemoglobin of 10. And then post-operatively, we have all these protocols, protocol-driven care. And this, when we did this, we involved the anesthesiologists in the OR and the nurses in the clinic and the people in the pre-op clinic. And I also got the blood banking folks involved, because, as you know, everybody doesn't want to transfuse these patients until their hemoglobin is down around 7. And so we had to have some healthy debates about increasing that hemoglobin goal. And with that protocol, we started in 2015, and then we initiated the protocol and did all of the patients afterwards up to 2016 with that protocol. And we compared the patients that were done from 2012 to 2016 to those that were treated after May 1st of 2015. And we, as I said, we're very liberal with our definition of spinal cord ischemia. This was any new lower extremity motor or sensory deficit. It was exclusive of other causes that we could determine. We defined patients as high risk if they were Crawford extent 1 to 3. if they had zone 5 coverage, so the portion of the aorta just above the celiac artery, or if they had a prior infrarenal aortic repair. This essentially is just a graphic of what I showed you before of our protocol. And we also had a rescue protocol that we used, which included dropping the drainage pressure, increasing the cardiac index, raising the mean arterial pressure above 100. We pushed their hemoglobin goal higher above 10. We used steroids, also gave mannitol. If you ever want to see something kind of neat with mannitol, go on YouTube and you can see that some neurosurgeons will give a whopping dose of mannitol. They'll give 100 or 200 of mannitol to shrink the brain so that they can get to tumors around the brain, and it's very quick. So they give the mannitol and you can actually see the brain shrink when you do that. Well, the same thing happens with the spinal cord. And so if a patient has spinal cord ischemia, if you give them a dose of mannitol, their CSF pressure goes down almost immediately, just within a couple of minutes. And so it actually works pretty well for that. And then we also do a stroke evaluation to ensure that their lower extremity deficit was not related to a stroke. So with this protocol, we looked before and after. There were 223 patients before the protocol, 70 after the protocol. This was just to show that we had an increasing number of more complex patients, so we were doing more and more fenestrations and more thoracoabdominal aneurysms over that time period. The preemptive drains went up to 100% in the extent 1 to 3 patients. For the patients that had suprarenal or extent 4, the drains actually went down, so we stopped treating the patients that were lower risk with spinal drains. And I showed the fluoroscopy time just to show you that I was still in my learning curve for this, which I think lasts forever. But we were dropping our fluoroscopy time, and our fluoroscopy time now is actually less than half of that time post-protocol there, so we often do extent 4 thoracos with 30 minutes or less of fluoro time, believe it or not. So this is the pre and post protocol data. So before the protocol, we had an overall rate of 13% spinal cord ischemia, and afterwards 3%. And then the blood transfusions, I show this data only to show you that the blood banking folks were really worried that we were all of a sudden going to have this tremendously high blood utilization, and really we were already kind of doing this before we implemented the protocol, so there wasn't really a big change in the amount of blood transfusion that we were using. These are the same data in graphical form. So on the left is all patients pre and post, so 13% versus 3%, and then we look at the high risk patients, which are those with extent 1 to 3 thoracos and previous aortic replacement. There was a really profound difference in the rate of spinal cord ischemia in that group. And then the interesting thing, even in only that 70 patient population that we did, we saw a survival benefit, which if you think back to the papers I showed you before, they should have better survival because they have less spinal cord ischemia, which is directly related to their survival. I haven't presented or published the data yet, but one of my residents actually just put this together, but we just looked at all the updated data. That paper was published in 2017, and we looked at an additional 5 years at UAB and compared back to the UF data, and we've seen a sustained decrease in spinal cord ischemia since that time. That's similar numbers, which was nice to see. So you probably have all heard of the U.S. Aortic Research Consortium. Some of these folks on this little map have moved. This is from a presentation that one of my residents gave at the European Society for Vascular Surgery a few years back. At the time of this study, we had 1,680 patients that we could look at their data after spinal cord ischemia, and this was essentially to look at the kind of combine the two papers that I showed you before from UF about preoperative prediction of spinal cord ischemia, and then also look at the ramifications of spinal cord ischemia when it occurred. We used data from 9 centers at the time. The data spanned 2005 to 2020. And then we referenced the thoracoabdominal patients to the juxtarenal patients who have essentially a 0% risk of spinal cord ischemia. We define spinal cord ischemia as anything from transient weakness, which we call paraparesis, or permanent paralysis. As I said, we had 1,681 patients. The overall rate of spinal cord ischemia was 7.1%. The permanent paraplegia rate was 4.2% out of that group. The multivariable predictors of spinal cord ischemia, not surprisingly, were the patients with longer length of aortic coverage, extent 1 to 3, older patients, We found that a history of peripheral vascular disease also was associated with spinal cord ischemia, and then red blood cell transfusion was related to it, but this was likely because the patients with spinal cord ischemia were getting more blood. So this is a Kaplan-Meier curve, just looking at those patients without spinal cord ischemia versus those with reversible versus those with paralysis. It really looks just exactly like the paper I showed you from UF years ago. If you recover, your survival looks very similar to patients that never had spinal cord ischemia. If you do not recover, you have a much worse survival over time. So just to summarize that so far, and then I have a little bit after this, and then we'll be finished. But as I said, and as you know, spinal cord ischemia can really be a devastating, life-altering complication, and prevention, detection, and treatment are key. I think that protocol-driven care is really imperative to prevent this. And you really must have this if you're going to have a thoracoabdominal program in your hospital. You really need to have a good prevention protocol, and everyone needs to be educated in that protocol. And the question still remains whether a randomized controls trial for CSF drains should be performed, and I don't go in great detail here, but there's still a lot of controversy here in the U.S. about whether CSF drains, I shouldn't say there's still controversy, it's really been developing controversy over the last 5 or 10 years about whether we should be using prophylactic drains. A randomized controlled trial is certainly ideal, but the question is whether there's clinical equipoise. There are 3 papers that, to my knowledge, of randomized trials for CSF drains. These were published a long time ago, so on the top there, this was published in 1998. That was 33 patients, so 17 versus 16, and they used CSF drains and intrathecal papaverin, which they felt was associated with reduction in spinal cord ischemia. On the bottom right was done right here in Houston, published in 1990, and this was 52 patients versus 46, and they did not see a difference in patients with and without preoperative drains, and hypotension was the only risk factor that was associated with spinal cord ischemia. The largest paper was also done here in Houston that Dr. Caselli published, and this was in 2002 and was 145 patients, and they found that there was a 80% reduction in the relative risk of postoperative deficits for those patients with extent 1 and 2 open thoracoabdominal repair. So the question remains about endovascular repair. I have still been fairly conservative about CSF drains, and I still put them in almost all of the extent 1s through 3 thoracoabdominal repairs. We have been working to create a randomized trial for prophylactic drains. In the process of doing this, we've done a pilot study at UAB and at UMass with Andy Schanzer, and we just did 20 patients to work out the protocol and determine if this was doable. That paper is in print now. But as we've been working through this protocol to develop a larger multi-center randomized controlled trial, we've been really looking closely at the data in the US ARC, and these data are unpublished, kind of hot off the presses. I did this just in advance of the Houston aortic meeting, but the rate of CSF drain usage over the last 10 years has plummeted across these groups. And so you can see this is the use of CSF drains we now had, at the time I pulled these data, we had over 3,200 patients in the US ARC, so it's a large number. And people are not using prophylactic drains very commonly. We looked at patients who had therapeutic drains, so drains placed only when they had a spinal cord event, versus the patients that had a prophylactic drain, and looked at how many of those had a permanent deficit. And the permanent paraplegia rate was actually the same in the 2 groups. And then if we look at survival, and I'm sorry this doesn't show up very well, but on the bottom is the postoperative therapeutic group, and then on the top are the patients who did not have a spinal drain but had an SCI event, and then the patients who had a prophylactic drain. And there does appear to be just visually appears to be a difference in survival, but when you look at it statistically, there was not a difference. So the fundamental question still remains is, does the CSF drain actually prevent spinal cord ischemia, or do you just have some benefit of having it there and draining earlier so you don't get that time period where you have to recognize the spinal cord ischemia event, get the people there to put the drain in, and then get the improvement in the patient's exam. Do they mitigate the severity of it? I would say that's pretty well known to be yes, just because we use them so frequently, even for therapeutic patients, and you will see a recovery in many of those patients. And I've used this slide a few times, and this question is there clinical equipoise for a CSF drain for a randomized controlled trial? And I always had yes here, and just recently I changed it to maybe. I don't know. And so we're pulling these data together to really decide if we want to do a randomized controlled trial. What we found is that we would probably need to have upwards of 700 patients enrolled in the trial to show a difference, maybe more. And so I'm not sure it's doable, nor am I absolutely certain that we should do it. So we'll see. We'll see, and I'll have all these data. I'm not being vague on purpose. We're pulling these data now, and I'm trying to make sure that we've got good, complete data so that we can decide whether we think there's equipoise for a trial. Thank you.
Well, thank you, Adam. Just awesome. Somebody who knows what they're talking about. So let me kick off the discussion. You draw these beautiful pictures of anatomy of the spinal cord and the blood supply. We pride ourselves here in imaging, and the imaging, MR, CT, all rolls up inside the Heart and Vascular Center. It's been singularly disappointing how little imaging has seemed to contribute to prevention of spinal cord ischemia, and yet it's all about the blood supply. Mm-hmm. What should we be doing in the future? We've got a 17 MRI scanner around the corner. It will give us sub-millimeter resolution. Is this something that you think there's any future in looking at identifying it and then doing something about it? Of course, they're two completely different things, but why has imaging really not helped?
And just to clarify, do you mean for prediction to help you?
Number one, defining, where the blood supply to this. I mean, we think of the anterior spinal aortic coming off the T8 to T10 level, and yet there have been attempts to catheterize it, inject dye into it, look at it with MR, and really don't seem to have impacted the ability to predict spinal cord ischemia and then figure out what to do about it.
Yeah, it's such a complicated thing. There's a ton going on in this field that I don't have in this talk, but so a lot of these patients have thrombus in their aorta and lose a lot of their intercostal vessels. You know that. I think that if you were to use good imaging and actually count the intercostal vessels that you're covering, I suspect that would probably matter. The issue is when you do a thoracoabdominal repair, there's always type 2 endoleaks. There's tons of them, right, by definition almost. And I kind of like to see them because I like this idea that they're sort of feeding each other. And if you take, and Carlos Timuron's actually done this, where you put the graft in and then I don't know if he does it on the table or right after, but do contrast-enhanced ultrasound of the aneurysm. There's tons of flow. There's flow through the graft and through all the little holes where the diameter-reducing suture was, and flow through the intercostal vessels. And so even if you look on the arteriogram and you think there's no flow, there's flow there. And so there's probably some protective effect of leaving those things open over time, I suspect. So I think it might work for prediction. The other question is could you use it to direct a staging mechanism rather than just doing a TVAR proximally and go and embolize the vessels? And there's an ongoing clinical trial in Europe for that. And they're reporting rates so what they do is they embolize the intercostals and lumbar vessels, and sometimes at multiple sessions. And they've reported a rate of 0 spinal cord ischemia, and I think it's over 400 patients at this point. And so imaging, in a sense, helps in that way. But those patients get sometimes 4 and 5 hours of embolization on multiple occasions, tons of radiation to the patient and to the provider. And so it's not necessarily a panacea, I think. But anyway, I don't know if I'm answering your question, but I do think that it would be a great way to predict it, but it would be very labor intensive to have, to go through and count these things. It'd be nice if you had some AI that could pick them out and count them.
Questions?
All right. Dr. Beck, great talk. Two questions. Did you say you prophylactically drain extents 1 through 3 when you're doing endothoraco?
Yeah, and I still have, and I know that, you guys aren't doing that much. But yes, I have. For the most part, I would say there's a few patients that I don't do it for various reasons, but I have still been doing it fairly conservatively.
And if someone loses motors in your ICU, are you targeting an ICP greater than 5 regardless of the volume you're draining, or you have a max volume draining? What's your protocol?
We drain to pressure, not to volume. So what we do is we drain to, we'll drop them to 7 millimeters of mercury or 5, and then we have a max volume that we do. Now that's another variation in the way the different centers do this, is some drain to volume. So they'll say they have a target volume to drain to and they don't care about the pressure. I usually say 15 or 20 in an hour, but the next thing I was going to tell you is that we started using a device called the LiquiGuard a few years ago, which is a closed system where the patient actually can get up and walk around to both pressure and volume. And so you can tell it, I want a pressure less than 10, volume no greater than 15, and it will regulate that as it goes. It's a nice system. They're expensive though. They're like $25,000, $50,000 for this thing. But the nice thing is an old patient, that you don't have to have them laying flat for days. They can the day of their surgery with a spinal drain in, they can sit up, they can stand up, they can walk around. Most of the time they don't walk around, but they do get in a chair and stand up a little bit.
So let me ask you a quick question. So one of the advantages of targeted use of spinal cord ischemia is when you put that drain in, at least in our institution, you're in the ICU. And then we go through this sequential, watch you overnight, then we clamp it for several hours. It essentially buys you 2 nights in an ICU after doing this. And so has it reduced your ICU length of stay?
Keep doing the drains increases our ICU length of stay, no doubt about it. And I don't know that device really decreases our length of stay. I do think it probably, if you looked at enough patients, it would decrease your complication rate. You'd probably decrease your risk of pneumonias, aspiration pneumonias. ICU delirium, is really bad with these older folks that are laying flat for days and they have severe back pain that's related to position and ischemia to their muscles in their back from these things. So you want them to get moving as much as possible, as early as possible.
Marvin?
Great talk as always. Thank you so much for coming down to Houston again.
Thank you.
When you do a lot of something, you get very good at it. And one of the things I guess we didn't touch too much on was the complication rates of CSF drainage, bleeding into, draining too much, subdural hematomas, etc. Do you think if we move away from prophylactic drains and rarely put them in, and now we ask our anesthesiologists who rarely ever put these things in to then do it on an emergent situation, trying to rescue somebody's cord, do you think we're going to be shooting ourselves in the foot?
Yeah, you as much made a comment as you did a question there. I get that, because and that's really it, right? That's the question. And so if you look in the literature over the last 5 years, there's a whole bunch of papers about spinal drain complications. And the interesting thing is that if you look historically in the literature, there was a lot less about that. And so it's almost like there's this epidemic of spinal drain complications. And I don't know if it's because people just really started paying attention to it, or if there's been a drop in the number that get put in, and there are more complications, because it's a skill set, right, to put these things in. And if you do less of it, you're less good at it. That's really the crux of this trial that we were trying to do, because we were not only going to look at the rate of spinal cord ischemia, but also the rate of complications, which is upwards of 10 to 15%, depending on how you measure it. So it's not low. And I would say, yes, if you do less of them, you're probably going to have more complications in that group. Now, we looked at that in the USARC. This is part of the data that I was just showing you that we're getting together. And the complication rate did look very similar at the centers that do a lot of them versus the ones that do less of them. So we'll see. The other complicating thing is some have neurosurgeons do it, some have cardiac anesthesia do it, some have IR do it, neuro-IR. Some people do it the day before and admit the patient. Some people do it the day of and anticoagulate them right after. There's a lot of variability there.
Second question is, can you touch on your strategy for staging some of these extensive coverage endovascular repairs? Are you leaving branches unstented and allowing that to perfuse the sac? Are you, not doing the larger main bodies down below? What's your kind of strategy?
In the history of my time doing it, I have had perfusion branches and I have had left branches open. Not really found a lot of benefit in that. So for the most part, my staging is pretty simple. I do a TVAR down to the diaphragm, and I'll leave enough space to put a branch in if it's a branch graft versus a fin. And then I do the completion repair, and that's it. And I don't tend to leave the branch open. But again, I'm putting drains in. So the sites that don't put drains in, tend to do leave perfusion branches or leave a branch open for some period of time afterwards. And if you look at Dr. Greep's data, it only takes about 3 to 5 days to see a change in the size of the capillaries around the spinal cord and the perfusion to the spinal cord. So, you could conceivably do it before the patient goes home if you're worried about that, if you keep them for 5 days. Or, if they're close by and you come back. Most of these places, the patients are coming from many hours away to get their procedure, and so we don't want to send them home and then try to bring them back 2 weeks later, because we're going to have a lot of patients who get lost and don't get their secondary procedure. So, short answer to your question is my staging usually is just the TVAR and then the branch repair. 2 to 4 weeks is what I do, if I can, and sometimes they'll get outside of that depending on how how badly they react to the first procedure.
Okay, so let me ask one final question. Obviously, most of this happens in the perioperative period, but there are a group of patients who get delayed paraplegia, and we're not real consistent in educating these patients. I mean, do you have a way of communicating with them about the urgency of coming back if they go home and have an MI or a GI bleed and suddenly they can't move their legs?
Well, nothing protocolized, but I do tell every patient, if you end up in an emergency room anywhere for any reason, I want a phone call, and I don't want a phone call when you're going home. I want a phone call when you're in the ER and you call and leave a message or whatever. And actually, these are all anecdotal things, but they change the way you practice. I had 2 patients at the same time that changed the way we were doing our transfusions. They were within a day of each other. One of them was 9 months out from an extent 2 thoraco. Had an upper GI bleed. She came in vomiting blood, was in the ER and vomited a whole bunch of blood, and she said, "I can't move my legs." And they did. She was hypotensive, and while we were calling to get a spinal drain in, they gave her a couple of units of blood, and she started moving her legs again. And then, and at the same time, I had a patient who drifted down on our floor and had a lower GI bleed. Stopped moving her legs. We gave her blood, and she started moving her legs, and we never put a drain in either of those patients. It was just the hemoglobin and the blood pressure that did it. And so that was all around the time that I was developing this protocol, because we had sort of a, maybe silly, but it was a aha moment. And we were like, well, this is really important. But yes, absolutely. I've had a few patients that are months out from their repair.
All right. Well, thank you. That was an awesome presentation, and probably need to look at our spinal cord protocol, because we drain the volume and not so much pressure, actually, in the patient who becomes acutely symptomatic. But thank you again for coming down here.
Bye. Yeah, thank you. No problem. Thank you.